Okay, we are live.
Yeah, good evening, everyone. I welcome all of you to yet another session on endometriosis related topics. So today's class focuses mainly on this one drug, that is GnRH agonist. So this is one of the most uh, potent drug which is used to suppress the hormones in a body of a woman, and this is really a wonderful drug if used very nicely. But I think it is misused, abused in so many ways, because many people fail to understand as to what is the limitation of this drug. So we have seen in our practice that there are patients who have been taken like more than 12, 13 doses of GnRH agonist for the disease, which is not even going to really work even with, like, 3 doses. So being aware of what is right and also what is practically possible from the drug is what this class is all about, and it focuses more on the practical points than on the pharmacokinetics and the other stuff about the drug. Yeah, over to you.
Okay, so I'll just share the screen. Just let me know if it is visible. Visible?
Yeah.
Okay, fine. I will be, dividing the class into four parts. One is the type of agonists which are available in the market. Second is, what we should know. Like, do we really choose an agonist based on our relation with the company, or do we choose it based on science? Okay. And that is going to be something which is pretty interesting. So basically, close to the pituitary in the brain, somewhere in our head, we have a region called as brain, and inside that there is a part called as pituitary. And pituitary, close to that, no, it has a part called hypothalamus. Okay. And in that region, you have basically the axis between the hypothalamus and the pituitary, which is called as the hypothalamic pituitary axis. Okay. In this axis, you basically have GnRH receptors. Okay. GnRH receptors are going to be basically receptors which are going to be acting when stimulated by gonadotropin releasing hormone. Okay. What is this? Just remember it in very, very quick, maybe 1 minute overview of this entire thing. It has got basically 10 proteins. Okay. It is a deca peptide, 10 proteins. Okay. Basically, in the human body, this guy is going to go and act on the GnRH receptors. It is going to stimulate the GnRH receptors and thereby cause secretion of FSH and LH. Okay. Now, there is a feedback loop. FSH and LH, both of these guys would have a negative concentration on GnRH. Simultaneously, estradiol and progesterone would also, everybody is going to be in a negative feedback loop with GnRH. Understanding? And that is the reason when we want to reduce the values of FSH, we want to reduce estrogen, progesterone, LH, everything. We have GnRH agonist. So basically, let's assume this is the GnRH receptors, and on that, you have GnRH coming and acting onto that receptors. So we have two types of molecules. One, we have GnRH agonist, which go and stimulate the receptors to go up, and then it causes them to go down. Or we have somebody which is an antagonist, which goes and binds to this entire thing. All right. Lot of principles, lot of huge applications as far as gynecology is concerned. But this is all that we need to know. So what we are going to be talking about today is GnRH agonist. So what it does is it goes and binds competitively to the GnRH receptors. And after causing an initial flare, that means after an initial increase in the value of FSH and LH, then it causes profound suppression. This profound suppression which it causes reduces FSH and LH to almost castration levels, thereby causing reduction of estrogen and progesterone. That is the reason when you are having endometriosis, you have the bladder, uterus, everybody like this. And when you have the endometriosis, let's say deep endometriosis here, okay, every place where you have an estradiol receptor or a progesterone receptor, This guy is going to cause reduction in these receptors. However, the only place where there is no receptor is the presence of a nodule. And as a result of this, your GnRH agonist never goes and works when you have nodularity. Okay. It may cause temporary reduction of size. It may cause temporary reduction of pain. But as soon as the effect is over, okay, the nodule will come back to its original size. Pain will be back to its original size. And as a result of this, GnRH agonist is only labeled for temporary pain management in endometriosis. It has got no other role as far as endometriosis is concerned. Simultaneously, we all love, we just love to use this drug as far as adenomyosis is concerned, because we think, or we are made to think, and of course, because the production is at this level of the drug, we are forced to believe that if the uterus is a bulky uterus like this, and if the lining is a skewed up lining like this, and if you have a large adenomyosis with the uterus approximately, let's say 12 centimeters in size, you basically keep on giving GnRH receptors till the uterus becomes 2 centimeters in size. Correct? Is it ever going to happen? The answer is no. This is only effective if the size of the uterus is less than 10 centimeters. Only then it is going to cause volume reduction. This volume reduction then allows you to do something called as HRT protocol for embryo transfer for preparation of the lining. And that is your practical application in adenomyosis. But remember, it is again temporary, size less than 10 centimeters. Beyond that, it does not work. Beyond that, it is not even recommended. Beyond that, it should not even be thought about. All right. Now let's look at the 3 most common available GnRH agonists in our country. Okay. So when I look at GnRH agonist in our country, the 3 most common people are Lupride. Second, Goserelin. That is also marketed as something called as Zoladex. And third, Triptorelin. Now, Triptorelin does not have a depot formulation which is easily available in India. All right. If you ever look at Lupride and just read what is behind Lupride, it is this name. Lupride acetate, you have Goserelin acetate, and you have Triptorelin pamoate. Okay. All these are stabilizing agents so that the drug delivery is very, very effective. All of them are 100 times more effective than the natural GnRH. Okay. 100 times more. Actually, Goserelin is 120 times more effective. Triptorelin is also approximately 110 times more effective as far as the routine GnRH is concerned. Everybody has little different substitutions which are done inside. Everybody is available as a depot formulation. So you have depot formulation of 3.75. This is guy is 3.6. You have 3.75. Zoladex is also available as 10.8. This guy is also available as 11.75. So it can go and act from a span of 1 month to 3 months. Okay. 1 month to 3 months. This is standard. All of them cause the same standard effect. All of them are going to be excellent as far as giving the patient hot flush is concerned. All of them are excellent when it comes to giving the patient osteoporosis. All of them are excellent as far as causing backache. All of them are excellent as far as causing hair loss is concerned. All of them are contraindicated in pregnancy. All of them are abused as far as endometriosis is concerned. All right. So now when we have everybody who is the same, what to choose? Shall we choose the person who sends us to Shree the most, or shall we choose a person who has some different clinical activity as compared to the other person? Now we can have people who will say, oh, I think Lupride is better than Lupron, and I think Lupron is better than Lupride. Oh my God, it is an ouch moment, because you know what is going to happen? The API to all of them is going to be supplied from the same person in Germany. So what typically happens is, no matter who is selling you as what name, the API is the same, and as a result of which the packaging is the same. Now remember, I'm sorry. We have certain brands which are more expensive as compared to the other brands, and that is because all the drugs are delivered like microspheres. Microspheres is, of course, a patented technology for each and every company. As a result of this, let's say this is Lupride. Let's say this is Goserelin. You have a polymer which is surrounding this. The quality of the polymer determines the quality of the drug, as a result of which the guy who the best polymers and the best disintegration medium is going to be costing you slightly more expensive as compared to other products. But just remember that in your mind. As a result of this, in our practice, this is in my practice, I prefer to use Zoladex when I'm given an opportunity as compared to anybody else, because Zoladex is one of those guys which has a beautiful patented technology of the microspheres, and it allows for an excellent sustained release. Okay. And you have many other companies which are available who have patents, who have copied patents, whose the patents have expired. And because the patents have expired, they may or may not have the same microsphere delivery technology. And as a result of which, sometimes you may feel that yaar maine Lupride diya par itna great kaam nahi kiya. It was not the problem of the Lupride API. It was the problem of the microsphere which was used. Actually, if you go into this detail, you will realize, as I told you in one line before, the company which makes the best microspheres is the company which you love the most, because that is the company where you will have a sustained action of GnRH agonist. Just keep that point in mind. How do we use it and how much do we use it? 3.75 injection can be taken at least 3 to 4 times once every consecutive month deep inside the buttock. It has a special delivery mechanism. The delivery mechanism, if you ever see what it is a pellet. So you have a large bore needle which goes inside the buttock and it deposits a pellet inside the buttock of all the drugs. Huh? This is not oil-based deposition. This is a pellet-based deposition. The pellet will disintegrate. It will be simply absorbed by the body and slowly the drug will keep on getting released. Correct. Some formulations are also available as once in 100 days formulations like Zoladex 10.8. Apart from endometriosis, they are also licensed heavily as far as usage in precocious puberty is concerned, fibroid is concerned, as far as gynecology goes, and of course for embryo transfer protocols when you want to give any of these drugs. And we have discussed ET protocols with these drugs in our masterclasses on fertility. One more thing which I thought I must add very importantly, we often talk about add-back therapy as far as giving GnRH agonist is concerned. If you give add-back therapy after giving any of these drugs in endometriosis, then it is superb. It is like, one hand you are slapping and other hand you are kissing the same cheek. Okay. So what is going to happen is that when you do something like this add back therapy, I've seen these doubts very commonly asked that I first gave Lupride and then I felt so bad for the patient, so I gave a Restadiol Valerate. Please do that. The nodule will be right there, pain will be right there. Only person who will change is the patient. They will change the clinic. They'll go to somebody else who will ask that doctor will stop that add back therapy and the patient will continue being there. Understanding? So don't make that mistake of add back therapy in endometriosis. One practical point. Second practical point which people have asked, can I give letrozole along with GnRH agonist? You should not. It has got no role. The receptor level action is there. It has got really no role when you give letrozole along with this. Can I put Mirena and Zoladex together? The answer is no. One question I was recently asked around 3 days back was somebody tried giving Elagolix twice in a day along with Zoladex depot. I felt really sad for that receptor. It's like Mumbai local train. Receptor has limited space and you are giving all the drugs acting on the same receptor. What will that receptor do? On top of it, you have down-regulated the receptor. No, by giving GnRH agonist. So Elagolix will just keep on fluttering around the body here, there, till it gets excreted. So don't try such type of gimmicks in life, please. Okay, because it is very funny to answer these questions sometimes when people call up in the middle of the surgery when we are on the aorta and somebody will ask, can I give a unique combination of Elagolix and GnRH agonist? It is so unique that you should not give it, one more thing which people have asked about GnRH agonist is sometimes there are some companies who have been offering GnRH agonist at a very dirt cheap price. Like you have some depots which are available at 1500 rupees, contrary to similar depots which are available at 5000 rupees. Which one to use? Okay. Remember, certain drugs, especially Lupride acetate, is under the DCGA guidelines. So it has gone under the drug pricing control regulation. So when it goes under the pricing regulation, MRP will get limited. And as a result of which, generic manufacturers will be able to charge less. Okay. I personally don't think it makes a big difference because, again, as I told you, if you don't have a patented microsphere technology, all this is not going to be much meaning to you. I prefer to use, I'll tell you what I prefer to use. I prefer to use Zoladex. I prefer to use 10.8 of Zoladex. It is available at approximately 20 to 25,000 rupees or so based on your negotiation with the company. And I think it is good. It gives approximately 4 to 5 months of suppression. Please use these drugs. This is my final line, and this is the most important line. Please use these drugs only after complete clearance of disease has been done in surgery. The most common time where the drug is used is you have left a bowel nodule inside, you have removed and punctured two small ovarian cysts, 2 centimeters each, and you have given Zoladex. In that situation, it has got no role. It has only got a role in microscopic suppression of the disease after you have radically excised all the lesions. Kindly focus on doing the surgeries with a good surgeon, getting the disease out from the body, and then giving Zoladex as a temporary suppression. Okay. So with that, I close, and I'll be happy to answer 2 or 3 questions.
So what is the highest number of GnRH agonist doses that you have come across in your practice? I
24.
mean, okay. So in these cases, have you
And the
ever
girl
checked
was
what
alive.
yeah, so sorry. Um, Sorry. So did you check the density of the bone in such cases to just check what is the damage that
No,
was
no,
done?
no. I did not. I did not.
So usually this happens in adolescent girls, like
Yeah.
when you want to try and prevent them from undergoing a surgery and they are in terrible pain and you have kept on giving painkillers, and then at a point in time you just are uh, at a loss of medications that you can give, and then you go on giving
Yeah.
agonist. So
Yeah.
in such cases with young girls especially, okay,
Yeah.
so how do we actually prevent the side effects? See, after 3 doses, maximum, I think 3 doses is what we can give, and beyond
Three
that
to
there is
four is
no role.
maximum, madam.
Maximum, yeah. So beyond
And
that,
3 to 4 of 3.75, not
yes,
10.8.
yes. So if it is 10.8, then I think it is only one
Single shot.
yes, single shot. That's what you can give.
Madam,
um
actually, that's the reason these drugs are called as temporary pain management. You know,
yeah,
even
yeah,
their package insert, if we ever get time to read, the package insert states that it's for temporary pain management and temporary suppression of disease. It is not
yeah.
for permanent suppression of disease.
Okay. So when we talk about this, the agonist, in your experience, so when you take the order in which you would like to give these medication, even post surgery, of
Yeah.
course, medical management is one. I don't think like we believe in it, especially in extra pelvic or even in nodular endometriosis. So if you are thinking of after a radical clearance of endometriosis, if we have to choose a drug, so when between ocipils or LNG IUD or
So,
agonist.
so we have this criteria, and I think we are exercising that criteria at almost all locations. In young girls, after complete disease clearance is there, we would like to put them on oral contraceptive pills.
Yes,
In girls who are having adenomyosis also, and where we have done microwave ablation, we would like to give them Zoladex, that is GnRH
yes,
agonist. Patients who
yes.
are planning for fertility, either nothing or Zoladex. Correct?
Yeah. So in such cases where you keep on telling give 10.8 of that Zoladex, but
No, no. I,
that,
I prefer to give 10.8. That's what I said.
yeah. So the cost is a major concern. It is a challenge with many patients that they
Yeah.
can't afford that 27,000 rupees for one injection. So in such cases, how do you weigh the advantage of this medication, especially post microwave ablation? I see you using it very commonly now. We never used to use it as frequently as we are doing it
As
now
I told you,
after
we
we.
only use it post ablation. And
Hmm.
what typically happens is post ablation, because there is so much necrosis which would have happened inside. Okay,
Hmm.
this suppression simultaneously allows muscle mass reduction. So when there is muscle mass reduction, a lot of this necrotic material gets absorbed completely. You know, and when it gets completely absorbed after 2 3 months, we see a massive volume reduction. I mean, the size of that adenomyoma goes down by almost 30 35%, madam, which is huge. as far as fertility benefit is concerned.
Okay. And these drugs, I mean, what is the like storage and is there?
Standard refrigeration, nothing else. Standard cold chain, 2 to 8 degrees.
Okay. So apart from this, I mean, do you see any role of these drugs? I know you don't do a lot of long agonist protocols in your
In
IVF
long
practice.
agonist protocol, we should not use a depot formulation, is my belief. In that, you should use the standard 0.1 decapeptyl or 0.5 ml of lupride, whatever you're planning to use. That is because the lupride which you are using is very shaky. That's what I was trying to tell. If the release is not very good, and if the technology is not very patented, the release will be very shaky. Some days there will be suppression, some days suppression is gone. Okay. As a result of which you give something which you can give daily, there is no question of, dependent on a polymer for it to disintegrate and release. Just your liquid based injection, which will go inside and 100% cause suppression.
Mm-hmm. Yeah, thank you so much. So, Aarti, you have any questions?
Yeah, Jay, I have a few questions. One, why is it that you prefer the 10.8 Zoladex and not the 3.75? Because I've noticed even post delivery after you do surgeries with us, you always ask that the
10.8. That's
Why?
because I just think it is a single injection which will last for 3-4 months. Okay. And any which ways post surgery, we tell the patient to not try for 6 to 8 weeks. No. So that suppression in a single injection once it is given to the patient. Plus, I think the beauty with 10.8 delivery mechanism, if you see, it can be given on the stomach. Okay. And it is really painless because the pellet goes right down inside the stomach. Fortunately, many women have good amount of fat there, and the disintegration which comes from that is very, very good, which is why I prefer that. But I think 3.75 should be equally good. I think so.
Okay. Another question, you mentioned that you don't prefer giving the depot injection before the frozen embryo transfer in patients with endometriosis.
Yeah. No, we
don't prefer it. Okay. And many people use it pre-operatively. I think you should just talk about how that is not a, good option.
I mean, people try to think that it will make the surgery easy. People try to think that, planes may be difficult. Actually, nothing like that happens, to be honest with you. Really, nothing like that happens. I mean, the surgery stays equally difficult or equally easy. So, I don't think it should be used pre-surgically at all.
Okay. And any difference in the dosages in mild and severe endometriosis?
No.
Milder,
Same.
you give it for, say, a
Madam, all this is for just suppression of microscopic disease.
Correct.
So the dose does not matter. It is simply microscopic suppression.
Okay. And what about adolescents?
I said I'll be very happy to use OCPs in adolescents. I've always considered using OCPs in adolescents rather than giving any of these osteoporotic medications.
Okay. And what about add-back therapy? You just mentioned you don't believe in it, but the only FDA approved add-back therapy is norethistyrone, and it is that
correct
recommended to be used if we are planning to give GnRH agonists more than 6 months.
More than 6 months, correct.
Yeah. So what is your take on that? Because
definitely, I mean, see, if you are suppressing somebody, I'll give you an example where add-back therapy is very good. Okay. And the answer is precocious puberty. If you use GnRH agonist suppression in precocious puberty, you have to suppress the girl for 12 to 16 months. In that, add-back therapy is fantastic. But in endometriosis, you can't be suppressing anybody for 12 to 16 months. And if you add back estrogen or progesterone, as I told you, you are kissing the same cheek which you just slapped. So it doesn't really matter.
Okay. I think I'm done. Thank you. Wonderful inputs.
Thank you so much. Thank you.
Thank you.
It was